is going on today.
I think it's the first time we've ever had everybody this far up. You didn't. Good morning. That's my habit, I guess, from Sunday mornings. Good evening. Good to see you here at St. Thomas. Welcome for those of you who it's your first time here. We're glad to see some of you again for a second time and other new faces as well. Just to get everyone on the same page, when you walked in, if you did not grab a green folder and then a stapled packet that says Pennsylvania Advanced Directive, they're on the back. And raise your hand. Father Ron will get one to you. And also a pen. You might want a pen. Ruth wants a pen in the very back, I think. Ron is coming by to pass some things out. I never introduced myself. My name is Chris. I'm one of the pastors here at St. Thomas. This is Ron, who's passing stuff out in the shorts. Yeah. So this is the second week of our 4-part series. Last week, we had a guest speaker, Reverend Marlena Cochran in, who's a hospice chaplain, and she gave a wonderful introduction about a Christian way to think about death and how we can also kind of minister and be present with our friends and family members who are close to death as well. So if you missed that, the whole entire talk is up on our website, stthomasanglican.org. You can go check it out. Tonight, we have two physicians, Dr. Alicia Topple and Dr. Catherine Hill, who happens to be my wife. And they are going to take us through kind of the medical aspect of what happens near death and how can we think about what we want our death to look like in a way. So I'm going to open with a word of prayer and hand it over to the experts. Father, we thank you for the opportunity to come here today. We ask that you would help us to let down our defenses. We don't always like talking about this stuff. Give us ears to hear the wisdom from our friends and our colleagues in the medical field, and help us to understand how we can be wise in applying that to our lives here, and help our families and family members talk through these things as well. In Jesus' name, amen.
Thanks. So we prepared some content and some kind of thoughts for you tonight to talk about what makes a good death, which, as you might imagine, isn't a super straightforward answer. We'll sort of take turns, but we haven't practiced this, so Alicia, if you have any thoughts while I'm speaking, please feel free to jump in. And also, for those of you in the audience, we'll stop a couple times on our way through for questions, and we really want it to be as interactive as you guys would benefit from and would want to make it. So we would love to interact with you and take questions at any point. So, who are we? As Chris said, my name's Catherine Hill. I'm a general surgeon. And then also a fellow in Palliative Care at UPMC. And I'm interested in combining those two things. So for people with surgical problems and for surgeons, improving palliative care for those patients. And the skills in palliative care for surgeons. And we'll talk a little bit more about what palliative care means, because that's a really unusual term that not many people have heard of.
Thank you. And my name is Alicia Topple. I have been trained as a cardiologist, so I do non-invasive cardiology, and I also do hospice and palliative medicine. My goal is really focusing on people with chronic illness, specifically serious cardiac illness. I also have a huge interest in things like medical education, communication skills training, and both of us have done master's degrees in trying to become better educators. And a few other things about me: I've got 2 kids. I've got a 6-year-old and a 3-year-old, and I'm a Navy veteran, but worked primarily with the Marine Corps. So we both have very good, varied backgrounds and are happy to kind of talk about any questions you may have at any point. So hopefully you'll find this very interactive and interesting, and we are looking forward to lots and lots of questions.
Great, so we'll start by sort of provoking you to be a little bit interactive and asking you, what is a good life? What are some parts of a good life? Family? I heard something else. Good health. Faith. Friends, yeah. Grandchildren. Activity, yeah. Sometimes grandchildren bring the activity. Yeah, great. We thought of many of those things: family, friends, faith, good food, good books, living your fullest, experiences or travel, independence and freedom. Oh dear, I'm going backwards. So what is a good death? That's a little bit of a harder question. It can differ based on who you are, your culture, your faith.
Last week, the chaplain kind of gave us
Great.
one without pain
Yeah,
in your sleep.
great.
And to expand on that, right, because we hear that a lot. We hear a lot of people say, I want to just go to sleep and just peacefully go. But there are many other aspects to that. Some people say, I want my family around me. Some people say, I don't want anyone around me at all. So I think what this brings up is how variable these answers are. Because my answer isn't going to be your answer.
What's hard about this question? No one wants to die? Yeah. So we wanted to also just verbalize that we want to commend you all for being here and for thinking about this and talking about this with us, because it's not easy to think about and talk about. And it is really individual. So we have from a few different perspectives, because in our world we often hear a lot of different perspectives on what is a good death. It sounds like you heard some of these last week too. So from a patient or a personal perspective, dying in my sleep, dying with dignity, dying without pain, dying suddenly. As you might imagine, it can be different from a caregiver's or a loved one's perspective. Maybe people would say without pain or suffering. I hope that they fulfill their wishes. I hope that they've experienced consistent care or treatment. And then it can even be different from your healthcare professional's perspective. Although a lot of the themes you'll see are a little bit similar: pain-free, peaceful, anxiety-free, or comfortable. And on a personal note from the two of us, we hope that our patients don't undergo medical treatments that won't allow them to have the quality of life that they're hoping for. So trying to find treatment options that match what they find to be an acceptable quality of life and what they find to be a good death. We get a lot of our experiences about healthcare from what's on television or what's in the media. So you might recognize some of these things up there, although I really don't.
Honestly, I had to Google some of these because I've been into octonauts a lot recently with my children. And so, but this is Code Black, Chicago Fire, and The Resident. But it looks very... New Amsterdam, I knew it. Oh, so close. I was stretching. You saw me stretching. But what they show isn't what we see.
We do hear kind of some common phrases sometimes from patients and families. One of those is do everything. And that makes us ask, what's everything? Does my everything as a doctor equal your everything as a patient? And when you're in the hospital, the focus is often on medical interventions and technical things that can be done. And from the perspective of patients and families, those interventions can be dehumanizing. So how we view hospital care is also pretty individual based on your religious beliefs, your culture, your personal beliefs. Yeah.
Which is the more difficult to hear from a patient? Do everything or do what you can?
So both of those. Equally.
Yeah, both.
I can do a lot. I can do a lot. And do everything and do what you can. We view, when I hear those, as the same. Because everything, why wouldn't I do everything? If someone tells me do everything.
This is is a really small font from back there, so sorry about that. But these are some kind of themes when many people were polled about what makes a good death or what's successful dying. Some of the sort of categories include location. Many people would like to be at home. And again, I will say that varies by culture. When we lived in Kenya, many people valued being in the hospital. Pain-free, your emotional well-being, sometimes life completion or feeling like you've reached a milestone, quality of life, using all the available treatment options, dying with dignity, sometimes having control over time and place, being at home versus in the hospital, the presence of family or wanting to be alone, spiritual satisfaction. I can't, page down. Having assurance in the afterlife. A kind of a life review or finding your life's meaning, recognizing all the people who've touched them and who they've touched, and having a say in your own care at the end of life, either through discussing your preferences or giving control to somebody you trust and love. How aware or social somebody wants to be. So sometimes people will want to have their symptoms controlled at the expense of awareness, meaning it's okay if I'm a little bit sleepy if my pain can be managed. Some people say, I'll deal with a little bit of pain if I can have some more time awake with the people I care about. But there's really no such thing as an external definition of what's a good death. And it's really dependent on the perspective of the individual who's dying. So, what do we do with that? The fact that it's so individualized. Most importantly, we can communicate about what's important to us. So we need to communicate our wishes to our family, our healthcare team, the people that we love and who love us. So that's where we, as palliative care physicians, focus a lot of our time and energy. So I will let Dr. Topol talk about what palliative care is.
So palliative care. Oftentimes when we walk into a room, people say, "Oh no," because they hear palliative care. But I want to ask you, when I say palliate, what does that mean to you? Anyone, I'm all ears. Reduce pain. I want to make you feel better. So palliative care, I'm not the doctor that's coming in to bring heavy news. Many times we come in for the extra skills that we bring. We come in to help with your symptoms. We come in to talk to you about what matters. We come in to communicate when things get so crazy and fuzzy because all these doctors are coming in and talking about really serious things and using lots and lots of really big words. And it's hard to stop them. And it's hard to say, whoa, 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 what does all this mean? When people notice symptoms are not controlled, communication needs to be better, or we really need to figure out what makes sense for this patient. That's palliative care. Yes, we do liaise with hospice, but when I look at myself as a palliative care doctor, my job is to palliate, whether that's communication, symptoms, or help however we possibly can. So we're a pretty broad definition. We're kind of jack of all trades, to be completely honest. There's a WHO definition, and boy, do I love my references. So we have this beautiful definition from the WHO, but really I want to focus on a few things. It's an approach. It focuses on quality of life for patients and children, their families. It's not just about the one person, it's about the whole family. And I think that's one of the reasons why Catherine and I love this. It doesn't focus on one tiny bit. It focuses on the broader picture. And I think that's great that you're having this seminar that focuses on the many aspects that go into this: spiritual, the medical, the legal, all of these things. You've got to think about this. And it's better to think about it now. But in palliative care, we want to relieve suffering, and that's through those different domains: physical, psychological, psychosocial, spiritual. So it's a long definition, but I like it. So who are we, and what is a palliative care team? We're doctors, we're nurses, we're volunteers, we're physical therapists, we're everyone. So when we meet in our palliative care team and we do our palliative care rounds, we're asking people like speech therapy, we're asking chaplains, we're asking volunteers, we're asking just about anyone to come in and help us, because that's what makes sense for the person. We do continue the curative treatments, so you can still be getting things like chemotherapy, antibiotics, getting all the care in the hospital. When you see us, it's not to say you need to stop. It's to say, let's really have a good conversation, a hard conversation, but a good conversation. And so we're going to work with you, we're going to work with your family, we're going to work with whoever your surrogate decision maker is, whether it's a friend, a neighbor, whoever, to help figure out who are you and how can we help. Busy slide, don't worry about it. Lots of words. It means we do a lot, right? We look at many domains. We look at many different things. So where do we fit in? When do you bring someone like myself? When do you bring someone like Catherine in? And it's really at any point in serious illness, best done early, because we get to know you. We get to know your family, what makes sense for you. We can advocate for you. We can let you know when the doctors are saying all that medical jargon and you have no idea what those words are, we can say, hey, this is what they mean. And we can say, I'm wondering, does this make sense based on the things that we've talked about? To make sure that we don't go back to that slide with the New Amsterdam versus what we actually can do in the hospital. So whenever people are diagnosed with serious illness, having palliative care, a palliative care advocate, really, really helpful. So again, who benefits? Anyone, serious illness. And so I love to get to know my patients. I learn so many cool things about them, and it helps me help them whenever things start to decline. So, how do you communicate your wishes? Yeah. So, some paperwork. And this is one of the beginning things, to start thinking about what makes sense. And in that advanced care planning document, it goes through a few different things. And I think it's page 4, that's like check boxes. It might be page 5 or 6. I like pages 5 through 8. So it talks about what makes sense for me if I can communicate with people. Or, it's okay if I can't communicate people. Can I bathe myself?
It's 9.
Page 9.
Page 9.
All right. So, no, that's okay. I'm going beyond my slides. I'm all messed up, but that's all right. But this is one of the places that you start. So this advanced care planning, when you start thinking about it, we're going to ask you some questions to say, ooh, that's a good question. Would I mind A or B? Do I say, ooh, this is unacceptable? Interestingly, advanced care planning, how many people have a living will or an advanced care plan already? Oh my gosh, you guys are superstars. Amazing, because not many people do. And I will say sometimes people do it with lawyers. Compare what this packet says and what lawyers also say. Make sure they make sense, because we ask questions in a different way. So many people want to talk to their doctors about advanced care planning and what they want at the end of life and what they don't want. But look, 92% when we do studies want to, 32% do. Now, obviously, you guys have well exceeded that, so I love this. But doctors, we want to talk about it too. But what is difficult about advanced care? It's hard to accept. What else?
I think it might change whenever the situation arises, because you're speaking emotionally and you're more involved, or right now you're planning. But when that illness would occur, and you've got family and people who are your surrogates, their emotions get involved. So you have to find that person who can be unemotionally involved, but still make the best decisions upon what you want to be for your end of life experience.
Absolutely. It's hard. It changes. When I'm in this situation, will I feel the same way? Absolutely. And who's going to speak for me if I can't speak for myself? What else? Yes. Yeah. Appointments are real short and they're always late. I know. We're always late. And then to actually have a really good value-based discussion is hard. It's really hard because the questions that we often ask are hard to think about. They're hard to say, ooh, when you say everything, and I'm talking about all these procedures, and you're thinking, whoa, 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 pump those brakes. I was not ready for this. And oftentimes when people are talking about this, they're asking about specific procedures. Do you want dialysis? Do you want a trach? Do you want a peg? And you're like, whoa, whoa, whoa. And it's not, I'll tell you, it's not about the intervention. It's about the values. It's about what does that intervention mean to me? And so thinking about when we talk about these interventions, what does it mean for the future? What am I going to be able to do? If I'm a person who really values being independent, living by myself, never living in a nursing home, will this get me there? So those are the questions, and time is hard. It's really hard. So one of the things that we kind of look at in palliative care and how we talk about these conversations often depends on people's illness trajectories. Sometimes when we're called in the hospital, we're called in and the person's in extremis, and we have to talk about these hard things no matter what's going on because we're staring at it right in the face. But sometimes with these illness trajectories, we actually have more time to think about it. We have many iterations of this, but these are the 4 most common, most basic. The top left is on when people experience something like sudden death, sudden cardiac death. They're fine until something big happens, and then they die. More common, we see things like terminal illness, like cancer. And that's our top right. Organ failure, heart failure, kidney failure, liver failure, those things. And then frailty. Those are people who have been declining over time, have dementia, and they become frail, and they have little bumps in the road where they're not where they used to be, and they have little kind of dips in how much they can do, but overall are just kind of really frail and failing. So regardless, it feels a lot like this, right? You're up, you're down, you're up, you're down, you're up, you're down. It's like whiplash. And it's hard to make sense of what is going on, and it's hard to say, hey, this is what I want, because you're on a roller coaster. And how do you slow down? How do you pause that roller coaster to say, you know what, we really have to have a good discussion? And so advanced care planning, that advanced part, so important. And you're right, this is an iterative process. It's dynamic. It's going to I'm not sure. Nope, there we are. It's going to change through time. We're going to plan early. Something's going to happen. It might change your perspective. What you write down is not written in stone. And that's why I love that page where you can check. It is important to me to be able to, say, communicate, to bathe and feed myself. And it takes you through very simple things to say what matters most. Because it's not about my interventions. It's about what are my interventions going to bring for you? What quality? How is it going to change your life for the better and sometimes for the worse? So we have to have these honest conversations early.
So, how do you start? Like Alicia was saying, talk to your family about specific things if you can think of them. And sometimes a document like this that gives a list is a good place to start. So what matters the most? Is it being able to interact with your family? Being able to feed, bathe, or dress yourself? To be free from pain? To not be on machines long term? Or I'm not sure. Or I'd be willing to go through all of those things to live longer. And then another good place to, just as a starting point, is to think about who would make medical decisions for you, which, as Kathy said, isn't always a straightforward decision. And then talk to your doctors. So this is one excellent resource called Prepareforyourcare.org. It's similar to this document in that it walks you through kind of the steps of thinking through things that are most important, and asks some specific questions. Do you have anything else to add about going through that site?
It actually, and it has some videos on there also. So this is a website that when you go to different states, advanced care planning documents can sometimes change. I think you put in which state you're in, and it will guide you through. The videos are very helpful. They ask some questions that are really helpful to think about.
want to go through the... Okay, so this is sort of what the document that's in front of you looks like. We're not going to fill it out all together here because, like Bonnie said, it takes time. And these are not simple questions. So as we said, choosing somebody that can make decisions for you, and then talking about what your healthcare choices would be. Your medical decision maker, there's a page for their information. And then I think the one we have is slightly different. Okay. It seems to have all the same parts, but I think the pages are a little bit different. So just don't reference the page numbers. But so this is that list of things that would make life worth living. As well as, if I am so sick that I may die soon, and then has some options. Try all support treatments that might help. If they don't work, I want to stay on life support even if I'm suffering. The next choice is try all the treatments that might help. If they don't work and I have little hope of getting better, I do not want to stay on life support machines. Or I do not want life support treatments and I want to focus on being comfortable. I prefer to have a natural death. I want my medical decision maker to decide for me, or I'm not sure. So I think that's one nice thing about this document is that it allows you to fill it out potentially many different times and at different times say, I don't really know about this page, but this one I have some definite thoughts about. And then it includes the ability to personalize your wishes. So if that list of 8 things doesn't include what's most important to you or you want to include other specific things, this would be a place to do that. I don't know if...
Yeah, so one of the things that I like to have people write on that form where you can write things in. For some people, they say, no matter what, I have to come home. For some people, they say, you know, living in a nursing facility for long term is fine. Most people in the middle will say, hey, if I've got to go to skilled nursing for a short period of time, get stronger, get better, and that's a realistic, that is good. I'm thinking long term. So if people say, I'm willing to do certain interventions, and we can go over some of those later, nursing home and nursing facility, that's one that I ask everyone to really think about, because for some people they say that's deal breaker. Sometimes people say I would be fine with that. And so that's a really helpful thing that we can kind of talk to people about early. The other interventions, those kind of come after you look at different values that we can talk about more specifics later, and you can pull us aside, and we're happy to talk about any of those. We can go past polls.
Can I ask if people have questions?
Oh, yeah, great time to stop, because I'll talk all day. Questions? Yes.
I have several friends who have no one, okay? And I'm trying to find ways to have this conversation with them, especially since Chris brought it to us. But what do you do when you or Catherine have somebody who has no one else and is having a very hard time making these decisions? Where do you go?
Yeah. So we have to follow legal. So for us, it's go by next of kin, and there's like a whole 8-step process. If there's no one, we try and find the person who knew them best. That's usually the person coming to visit them in the hospital. Because if we're trying to make medical decisions, we've got to make medical decisions that are going to be in alignment with what they would want.
Oh, great.
So friends, so, right, yes. But I also hear you asking, how do I talk to them about this? Because you're caring about your neighbors and you're thinking, oh, I'm seeing one of those declining things from my little graphs. And you're saying, how do I talk to them? And I think one of the ways that you can ask them is, I want to get to know you a little bit better. And to just ask them, if you were to get sicker, or when you are to get sicker. Say you go into the hospital and you're not able to talk to the doctors. What are the things that are important for me to know and for me to communicate to the doctors? And you can ask, some of these same questions on that advanced care planning. If they were to say that they needed to do all that stuff in the TV, all those machines, is that something that you would be willing to go through? What's most important to you? What are the things that are unacceptable, right? Because a lot of people can say, oh, I'll go through a lot. But then you start saying, what are the things, if you've seen someone else in the hospital, how did it go for them? What are your thoughts, right? So these are a lot of the questions we ask people. One of my first questions is, do you have a living will? Because it tells me you thought about it. Second question is about the values. How much are you willing to go through? Because it might happen that we might have to help you if you're not able to talk to the doctors. And that's where palliative care is also really helpful.
You've had an attorney do your living will, and you compare it to the documents that I'm going to look at and review, and you see that you need to make changes. Can I just make that as an addendum to the living will and communicate that to the person that's in charge of that, or do I have to redo that with an attorney?
So these living wills are valid when you sign it and two witnesses sign it.
Okay.
The two witnesses, one, they cannot be from your medical team or from the hospital. They have to kind of be someone not related to you. I would say if you've got multiple documents, the few things that you really do need to do, talk to whoever is going to help make those decisions. That surrogate decision maker, because when they see that document, they're going to go, this is what she told me. They want to make sure that it's the right one. So communicating, say, hey, I want to talk to you about these things. Let's sit down and just have a conversation. I know it's going to be uncomfortable, but that's okay. I want to know that you can tell the doctors what's important to me if the time were to arise.
In my family's experience, we've had, this was over 20 years ago, so I'm hoping things have maybe improved. But my aunt, who had a director, her son was an attorney, had a medical emergency the weekend of Thanksgiving, and she was brought into the hospital, and she was put on life support. She had respiratory. And that's not what she wanted. Yeah. And her son had to do a lot of finagling to get her off of that. Does that happen frequently, infrequently, or how does the hospitals handle things like that?
Great question. So, there are many documents that we have. Living will is one. A POLST, or a Pennsylvania Order of Life-Sustaining Treatment, is another. Having, and we'll talk about what those, they're similar but different. Does it happen? Unfortunately, it does. And it depends on who knows and what's going on in the circumstance. Because when EMS is called, their job is to full court press. And so they're going to full court press. Unless people have, sometimes they have little bracelets or necklaces. Sometimes they have these POLST forms, which are these Pepto-Bismol colored forms that say things like, do not resuscitate. If I were to die, comfort measures only. And sometimes people will put that actually on the side of their fridge. So EMS will oftentimes, if you're at home, try and find those. And then when people come to the hospital, if one of those POLST forms have been filed at the hospital or with their doctor's office that has, one of those communicating electronic medical records, then sometimes we can see that often and then say, these were their wishes. And then what I do is say, does this still stand? Because things may change. And so I say, does this still stand? And if that's the case, then I will follow what is on that order.
Thank you for talking about that form, because my mother just passed away at 91, and she was very concerned about, she had a living will, her doctor had it, but she said, those aren't always the first people to see you. And so she had it, her and I had a conversation about the Pepto-Bismol pink form.
Yep.
But that's not, I don't know if that's common knowledge.
It is not.
I mean, my mom had it posted on her refrigerator,
And there are 2 sections on that one. And yep, it's a legal form. It's a doctor's order. So if it's presented to EMS, then they will not do the things like CPR. They will not do those things like put you on machines. And that makes sense for people from time to time, right? That really does make sense. Why would you go through all of that if it's not going to get you back to being with your daughter, being at home? This is that pulsed. I only have it in black and white, but it is usually it is bright starburst pink like Pepto-Bismol to make sure that people can see it. There are multiple sections. The first section says, do I want something like that CPR? So it says CPR yes, or do not resuscitate, do not intubate. So that's the first section. The second section, it talks about the different levels of treatment. I would like comfort measures only. If I am to get so sick that I am dying, make me comfortable. I do not want ICU transfers. I do not want things that are going to prolong my life. I want to be made comfortable and let me die peacefully. The second one is limited. So the limited one says, I want to go back to the hospital. I want to receive things up until you're going to talk to me about things like intubation, things like machines. That's not within my values. And the last one is full treatment. So you can check all of those, and then you sign it and a doctor signs it. There are other box C and D. C is on antibiotics, and then D is on artificial nutrition and hydration. Those can be complicated topics, and we can definitely talk about those. The 2 boxes I care about most when I'm filling out this, A and B. Sometimes I just cross out C and D. Because it has to be filled out by a doctor, I do not think it is on my chart. But it's something that you should complete with your physician. So if you say, I want to fill out a POLST, just about every single physician will have that POLST. POLST, so Pennsylvania Order for Life-Sustaining Treatment. Pennsylvania Order for life-sustaining treatment.
my mom lives in a senior retirement community, and her pulse is right glued on the refrigerator.
Exactly, and that's where they tell everyone to put it. If we can standardize where it is, then EMS always knows to look there.
Sounds like an upgrade from back in the 80s. They used to put your list of your medicines on your refrigerator.
I like that still on the refrigerator too, the list of meds and the POLST. Yep, that's very helpful too. I will say I do very much enjoy when I get an active list of medications that people are taking. The electronic medical record is great for a lot of things, not always fully updated.
I would also say probably equal to the POLST or an advanced directive is deciding on that decision maker and identifying it to your emergency room doctor, your EMS provider, that person that knows your values, because obviously not everybody knows about this form, not everybody has this form, but having that person who can say, this is not what she would want. And as you said, Lois, unfortunately, it does happen where that person has to kind of come in afterwards and make those sort of excruciating decisions, and that's unfortunately still happens. But having that person at all is a step ahead of many people. Father Ron.
So what I think has happened over the last, say, 20 or 30 years is the number of options that an individual has detailed we can become and how specific about the kinds of care we want. The other side of that is those are complicated questions. Is your family physician the person who would sit down with you and walk you through questions like, what does it mean to be intubated, or what does it mean to have a feeding tube? Explain that to me, and the pros and cons. Is that where you go for that, or are there others or organizations that provide that kind of counsel?
Yeah, I think your family doctor is a good place to start to talk about sort of specific things. As we've tried to highlight, often it doesn't matter so much the specific intervention, but it's thinking about, what does that mean for my life? What does that mean for the outcome? And sometimes that's specific to you and your situation, so it's not always going to be possible to plan everything in advance with your family doctor, and sometimes it is going to depend on the illness or the situation in terms of what those different interventions mean. A feeding tube doesn't necessarily mean the same thing. It rarely means the same thing to any two patients, and it actually could mean different things even at different times in your life. But do you know of other resources for specific?
I think family physicians, perfect place to start, right? Those are the people who know you the most. Those are the people who have been through this with you for so long, right? You've built that relationship of trust, and they've gotten to know who you are. Because it goes back to our first question, what is a good life? And that's the biggest question. What is a good life? Because we are talking a lot about end of life, but what is good? What do you want that to look like? And just like Catherine said, right, the difference of a feeding tube for someone at end of life or someone who's dealing with, say, a gastric cancer, totally different. So if you're going to say, hands down, absolutely no, and that's your feeling, absolutely. We live in the gray. And so knowing which questions to ask your physicians, what does this mean for my life going forward? Is this going to be permanent? How is this going to change who I am and what I can do? Those are the important questions, because as technology changes and improves, we can do, when people say do everything, we can do a lot. And there are things that I learn about as far as interventions every day that I had no idea about. The technology's changing. So it's not about the specifics, it's about who you are, what you're willing to do. Family physicians, great place to start.
What happens, what does the doctor do if a person has a living will and says, I do not want to be intubated, and a spouse or a child says, I want intubated?
Yeah, that's where that Pennsylvania order of life-sustaining treatment, that pink paper, when it's a doctor's order, and that's what you say, that's what goes. Now, the question that Catherine and I will always ask is, what's that secondary meaning? Why? What are they hoping for? Because I'll tell you, when your kids and your loved ones they say, do everything, they're scared, they're sad. They don't want mom, they don't want dad, they don't want brother to die. They love you. And like we talked about, we want to live forever. But that's not realistic. And so they're scared. And so that's one of the places where palliative care, we can come and sit and talk. Because people are often grieving. We love our family. We love our friends. These are hard circumstances when we often meet people in the hospital. And a lot of it boils down to being sad and not wanting to lose that person.
Technology is it's important to talk with, not just read it and assume. My dad passed in 2000, and my mom was very upset that he, I really can't remember if he had a pulse, but she saw in in some paperwork somewhere that hydration, and I just looking at a copy of it that I have here, artificially administered hydration / nutrition. And the very first selection there is no hydration. And I guess my mom read that and thought that he was just didn't want water.
Mm-hmm.
But he was begging for water.
Yeah.
It was a misunderstanding that it was, what you don't notice is that it says the last two words are by two. And he would have been able to have water, but they were afraid of his aspiration of water in this case. But in fact, when they left, she was giving him ice, crushed ice, just to have so much to come out.
Absolutely. Do you want to talk about this? So this is one of the most common conversations I think we probably have when we're talking to people at end of life. And you're right. It's about fluid that we give artificially through a tube. Oftentimes when I'm talking to people who want to be made comfortable when they are dying, and as they are dying, I say, we know there's a risk that it's going to go down the wrong tube. But if pizza or beer or ice cream makes them comfortable and that brings pleasure, usually it's only a bite or two. Give it to them. We have many ways of making sure that people get that sensation and the taste that brings them pleasure. It's often about giving people IV fluids, but as your body is dying, those IV fluids often don't get to where they need to go. So it may prolong things, but not in a helpful, quality way. Oftentimes it goes into lungs or legs or, that interstitial kind of tissue, and it just causes swelling and discomfort. And so we talk about that because food is love, water is love, ice chips are love. The things that we cook Thanksgiving meals because we love people. I hate turkey, but I'll make a big turkey every single Thanksgiving. And I think it's gross, but I still make it because it's Thanksgiving and that's love. And I'm going to make this enormous spread for my two tiny kids who also hate turkey. I should make a chicken, I know. And we make all these things that are just leftovers for weeks because that's love. My cooking and my feeding them is love. At end of life, food through a tube doesn't bring pleasure. Food in the mouth does. And so that's what we recommend. But it depends on the family, right? And I will only make a recommendation that is congruent with that family and with their wishes. But you're right, it's the details. And it's written, that's why I only kind of talk about the first two sections on this post, because the other two, it does take a lot of time to really kind of talk about what it means to us and what it means to the family. Because if you go through it too fast, a lot gets missed. What other questions?
I was also just going to mention on that topic that it can be really distressing to folks who are watching a loved one at the end of their life that they're not eating or drinking, and then there's this thought of how can we don't we have to give fluids through the IV? And I think it's really important to keep reminding ourselves that when you're dying from an illness, or even when you're not dying and you just have a cold or feel terrible, you don't want to eat and drink. And that's the same way at the end of life, is that just naturally your body no longer really wants to eat or drink. And that's normal. And as Dr. Topple said, the IV fluids can often bring more discomfort than relief. Yeah.
You gave somebody something to eat or drink, and they aspirated it.
Yeah.
Could you get in trouble?
Good question. But we often see people at the end of life, again, making this decision that we know that there's a risk of aspiration,
but it's worth it to them to have a sandwich or a bite of a sandwich. And so no, the answer is no. If you and your family and your loved one have made the decision that there's some risk to aspirating, which is just getting it in the wrong tube, but we don't want to go with the artificial nutrition, and we'd rather just let them have some ice cream, or if that's what they want, no one's gonna get you in trouble. Yeah.
They are two separate documents. So a living will is something that we look as a guideline. These are your wishes. This is what you are telling us. This is who you're designating to be your decision maker. The post is actually more of a legal document, a doctor's order that says, these are the treatments that you are allowed to provide me and not allowed to provide me. The living wills can sometimes be overridden, depending on how they're written, by decision makers and by next of kin. It gets to be a little tricky legally, and that's why I'm glad that you're having a lawyer come, because in that living will it says you're giving no flexibility, some flexibility, all flexibility. And so that helps guide us, because when I am reading your living will and I'm going to talk to your family and say, these are the wishes that she has expressly stated, and this is what we will do, it's sometimes can be overridden legally. Very rarely, but they are two separate documents. The post is kind of the down and dirty. That's that pink form. This one helps guide decisions.
And this one can be considered a living will. Keep the PA. That's, I think, what she's asking.
Yes. That is a living will. Yes. I misinterpreted that. Let's skip it.
I'll just say, one of the things that we've brought up as kind of like the main two boxes on that form is the idea of receiving CPR. We had some slides here about things that you might be asked when you come to a hospital, which is usually about things like that. You want to this one? Okay. And so it can be confusing, and it's sometimes confusing even for your doctors. And so one of the things that is said, as we've mentioned, is do everything. When I think about what that means, it means no matter what. We will do machines, interventions, procedures, no matter how much a person is able to interact, no matter how much they'll be able to do in the future, no matter what sort of the outcome might be. We also hear people say, I don't want to be a vegetable. This also means different things. For some, it means not being able to communicate. For some, it means not being able to care for themselves. For some, it means relying long-term on machines. We also hear, I want to be comfortable. And so comfort means that even if it means that time might be shorter, we'll focus on symptoms. And then for other people, it might mean just not doing certain invasive procedures or avoiding pain during certain invasive procedures. So it means sort of different things to different people. And so, like I said, one of the things that we try to talk about with every patient that comes to the hospital would be if you were to get a lot sicker, even if we don't expect it. And often I will reassure my patients, we don't expect this for you while you're here in the hospital. But just in case, if you were to get a lot sicker, if something unexpected happens, we would do CPR and put you on machines. Have you thought about that? We can kind of go through this a little bit more briefly. But again, learning from TV, people have actually done studies where they've published all the TV that they've watched and documented the outcome of CPR. So survival from CPR on TV is about almost 70%. In real life, it's not like we see on TV. And I even say to patients, it's just really not like we see in the movies and on TV. We know that for everyone, about 15% live to be discharged from the hospital, and that hasn't changed for the last 30 years. I wish medicine was getting better at resuscitating people, but it's not. And then things affect that. So 15% is often kind of a top estimate that we can give people. Many of the patients that we see with chronic illness or the elderly or have cancer, their likelihood of surviving is in the single digits. And that's a surprise to a lot of people. I think we've covered a lot. I wouldn't be surprised if there's even more questions. We had some more content at the end sort of about how we're different from hospice care. If there's questions specifically about that, we're happy to talk about it. But people have so many personal experiences with the healthcare system that I wanted to make sure we take the time to invite your questions. And then I think we can close. Yeah. I see.
I know, hospice has changed a lot from what it was originally intended to now the insurance companies seem to say, once you're on it, then you have no interventions. And this seems to be something.
I see.
Palliative care, which we're about to talk about. Yes, you can still have some.
Right. Yeah, so the question is about sort of hospice you can kind of be eligible for or not eligible for. There can be limits on the types of things you can receive while you're in hospice because your goals have changed. Whereas palliative care, I would say that it's sort of just a different entity, meaning we're a medical specialty that can be asked to see any patient in the hospital or in the clinic. So like you might go see a cardiologist, you might go see a palliative care doctor. While you're in the hospital, you might have an infectious disease doctor, you might also have a palliative care doctor. And then there are, just like the infectious disease doctor might have a clinic where they see patients later on down the road or when they're home, we also have clinics where we see people just like any of your other sort of medical specialists. I don't know if that helps sort of reframe.
Correct. So hospice is, so maybe we will go over this because isn't palliative care also hospice care? Common question that we get, and we'll talk about what those differences are. Because we put in here, if I meet you in the hospital, does it mean that I'm dying? And hopefully I belayed those concerns early, because the answer is no. So palliative care, anyone life-limiting serious illness. Hospice care, someone with a life-limiting illness with a prognosis of 6 months or less. Now you're right, the original hospice was made for people who have cancer. It's sometimes it's a lot easier to predict than in people that I see with things like chronic heart failure or say kidney disease and things. It's harder to predict in chronic illness. We still can kind of predict because we're nerds and we have calculators and things like that we can kind of create these models. But it's a difference. So hospice is about life, and it's about quality of life. It's making sure symptoms are controlled. We focus on the whole being and the family. And people think that it's like, oh, they put them out to pasture. Absolutely not. It's aggressive care. You've got a nurse coming to your house. You've got PCTs coming to your house who are medical aides. You have social workers. You have chaplains. You have different people making sure that you are getting quality care. Hospice care. Your prognosis is 6 months or less. It's when treatments aren't working. Things like chemotherapy it's not treating the cancer. Or my heart failure medications. I'm having to dial back on all the heart failure medications because no matter what I do, blood pressure is low, or different markers are telling me that these medications can't be tolerated. And so, or you just say, you know what? I've had it. You doctors are doing too much crazy stuff to me, and this is not bringing me happiness. This is not getting me where I want to be, with family, with friends, eating that good food, drinking that good wine, going out and doing those things that I want to do, that we talked about at the beginning of what makes a good life. And so, am I skipping? Okay. Hospice care, it is a Medicare benefit, so it's paid for by Medicare. Oftentimes they dial back on a lot of different medications and treatments because they're not working. And so things will change. Medications will change, doses will change. We talked about all the different people who are involved, and they help provide that medical equipment that you need to take care of the person. Something like a hospital bed, a bedside commode, a bedside table, things to help take care of a person in the home. Now, I'm specifically talking about hospice at home, but it is done in many different places. It's just a little bit too expansive to talk about all those things. Hospice is not a place, it's a type of care. So many people think hospice is only at a hospice house. It can be done at the home, at a personal care home, skilled nursing facility. Sometimes we do it for people who are dying in the hospital. It all depends on what makes sense. There are many different agencies out there. Big ones, little ones, national ones, local ones. So what hospice isn't, it's not stopping all care. You're still going to take medications, but we're going to look at the medication, and I'm really going to say, ooh, is that metoprolol that's making them feel real crummy and fatigued? Is that a good medication to be on? Probably not. But if I have someone who's got, you guys have all heard of AFib, and their heart rate races without their metoprolol, I'm going to say, yeah. And if their heart rate's racing, I might go up on it as long as they can tolerate it, right? So we're going to look at each person individually. It's not stopping all medications. It's not only for cancer patients. It's not giving up because you're still doing the things to bring that quality of life. It's not giving people morphine so they are sleepy and we hasten death. And it's not a place for people in their last 2 days of life. So here are some things that kind of look at what palliative care is and hospice care. There's a lot of overlap. Really, it boils down to the 6 months prognosis. When you want to see someone in palliative care, there aren't a lot of us around. I will be totally honest. We should have more palliative care doctors. We should have more palliative care clinics. They're really hard to come by. UPMC does an amazing job. And actually, AHN, they also have an amazing program. They had a program called Aspire. It's changing slightly. They're losing the name, but still with some of the functions. But we do try and have different disease clinics. So I have a heart failure clinic. We have a nephrology clinic. We're trying to work on a geriatrics clinic and what we call disease agnostic. So anyone with life-limiting illness. We are trying to kind of make sure that this palliative care really becomes something that people aren't afraid of and people talk about because it's really important. We believe so, but we're also, a little biased. So it is out there. I kind of went forward a little bit to this advanced illness care program. So people who this is the UPMC product. Highmark had their Aspire product. I think that one's going away November or December. I'm not really sure about that one. This does have this is for people who are really ill, really would be eligible to go into a nursing facility or having a lot of trouble kind of taking care of themselves. They have palliative care nurse practitioners, nurses. They really try and help empower the person to stay at home. There's also this community life program, which is a really wonderful, comprehensive program with the same goals of helping maintain people who are elderly and maintaining their independence at home while providing them the care. That is some of our clinics. But there are programs out there, the programs and the palliative care. I wish there were more of us, but we are out there. We need more questions.
Yeah, go ahead.
I want to make a comment. I didn't when I first. My mom is in a nursing home, and she's under hospice care now. And when I heard, what is she talking about? And she's saying that we're there for the family too. Especially, I haven't heard the word COVID mentioned now. COVID times, horrible. It's just horrible. We took my mom, I used the term, dropped her off at this nursing home and on the 1st of September. And it wasn't until September 21st we actually got to see her in person. That was not good. But the hospice, the woman who does visit my mom from hospice services, she was a godsend. She was able to communicate. My mom isn't even using the phone, and she's declining. But she reports to us, and that's a whole lot better feeling than just wondering what's going on.
Yeah, I thank you for sharing, and that COVID has certainly made illness in all settings extremely isolating and so hard for patients, and sometimes even harder for their families and loved ones. And I'm really glad to hear that the hospice experience has brought a tiny bit of relief for you and your family. Do we have time for one more? Go ahead. So we are mostly located in the hospitals. So we're at UPMC, so there are different palliative care doctors at all of the different UPMC hospitals. And then there are outpatient clinics, like we mentioned. We wish there were more, but the ones that Alicia mentioned, and also integrated into things like Hillman and the cancer clinics. And we also do telemedicine. And then there are a couple of specific UPMC nursing homes that have a palliative care staff member or nurse practitioner or somebody that's there as well, but that's even more rare.
All right, just a few comments before we close. First, thank you so much, Catherine, Alicia, thank you. Tremendously enlightening in a field that is just, it seems, is advancing so quickly and for the good. And we'll pray in a moment for your ministry and the work that you do. It's so valuable to us all. Couple quick things. We have coffee and cookies in the parish hall through those doors. We've got mugs in there for everybody. Feel free to come in, help yourself to one. And we are not asking any fees or donations for this particular program, but we are taking up a collection in the plate in the back, which is going to the UPMC Benevolent Care Fund. And that is the work that UPMC does to deliver care to folks who have literally run out of assets. They've come to the end of their financial resources, and they continue to receive care, and the Benevolent Fund helps to provide that. So if not tonight, perhaps next week or the following week, if you feel so led, you can leave something in the plate that we'll forward on to them. With that, let's just close with a prayer. Lord, we give you thanks for this evening, and we give you thanks for the work and the ministry of Dr. Hill and Dr. Topol and the whole team that works in palliative care and in hospice care. Lord, these folks truly work in a way and as your hands in the world to ease individuals and families through a time of transition in life from this world to the next. And we thank you, Lord, for their wisdom, their willingness to be with us tonight and share what they know. Lord, you know the concerns that each of us bring this night, some of us who may be dealing with these situations right now for themselves or for a family member, a loved one. And we just ask, we literally lift up to you those situations, Lord, and ask you to take them into your hands and to provide the comfort and the care that is needed. Lord, thank you for this time. We ask all of this in the name of your Son, Jesus. Amen. Please join us.